Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. Today I'm really happy to host Giuseppe Caruso, who is from the European Institute of Oncology, Division of Gynecologic Oncology in Milan, Italy. And we're going to be talking about a recent review article titled Lymphadenectomy in Early Stage Ovarian Cancer. Is there still a role? Giuseppe, thank you so much for accepting our invitation, and thank you for speaking with us about this very interesting article.
Thank you very much, Pedro. Thank you for the invitation, and it's always a great pleasure, really.
Excellent. So, really, of course, obviously, a topic that often comes up in discussion pertaining to the role of lymphadenectomy in patients with early ovarian cancer. Um, as we know, surgical staging, of course, obviously, is a cornerstone of ovarian cancer treatment. But the necessity of removing pelvic and parietic lymph nodes in early stage is really becoming, really more controversial. And I wanted to just start by asking you as to why did you and your team decide to look into this specific question?
Thank you very much, Pedro. Actually, the idea came while I was helping Professor Nicoletta Colombo preparing a presentation for a congress that was the Global Academy of Women's Cancer in Munich 2024. And the presentation was, a debate on the pros and cons of lymphadenectomy in early stage ovarian cancer. So Professor Colombo had to talk about the cons, and Professor Manner actually was going to talk about the pros of lymphadenectomy. And when Professor Colombo asked me, to help her with the presentation, I thought, oh my God, like we're still talking about lymphadenectomy and ovarian cancer. I thought, like, this is a very old topic. So at the beginning, I thought it was going to be kind of a boring debate. But then while I was studying, and looking, to find some new perspectives on this topic, actually, I can, list at least three main reasons why it is still relevant to talk about this topic. The first one, and I'm sure we are going to talk about it, is that, we have recommendations from the guidelines, but actually, these are not so clear. If you look into the guidelines, there's just a very brief section with just a few broad sentences, and they don't, go into details about histology, grade, biology. So very, general statements. And so, I had to struggle a little bit to find the rationale behind each indication to really understand why we should or not perform lymphadenectomy. And also, I saw that there were some recent updates. We are going to talk about it, but for example, there was an interesting paper from the Gemelli Hospital that raised some concerns regarding the role of lymphadenectomy in grade 2 endometrioid ovarian cancer that was kind of different for them compared to the grade 1 endometrioid ovarian cancer. So still we are, collecting data on this topic. And the other one, I think the most important one, is that we are now in the era of precision oncology. And so, of course, there are new perspectives when you think about lymphadenectomy. And it's not just that ovarian cancer is not a single disease anymore, and we really need to differentiate across histologies, but it's also that now we have a lot of targeted maintenance therapies for ovarian cancer, and this is very important, and I'm sure we are going to talk about it. And also we have new emerging tools like sentinel lymph node, artificial intelligence, ctDNA, and so there was a lot of new evidence and new advances. And so I think this topic is, still not so old as we may think. And this is why I then decided, because I studied a lot for the presentation, Professor Colombo is very demanding. And so I was studying a lot. And then I decided to write down a paper with this structure that I think is very nice. So all these clinically relevant questions where you try to collect all the evidence and then come up with a very short statement, and then a table where you look across the histotypes and really understand not just the recommendation, but why, the rationale behind each recommendation. And so this is why I thought about this paper, and it just started with a presentation.
Excellent. So perfect introduction to that. And you mentioned guidelines, right? So actually, I want to ask you, what do the NCCN guidelines or ESGO guidelines tell us about whether to perform a lymphadenectomy versus sampling in the setting of early stage disease? I don't think that there's any guideline that says don't do anything, but what do the guidelines tell us today?
Yeah, so this is kind of surprising, because if you look into the NCCN guidelines, the latest guidelines, for example, I just looked them like today before, this podcast. Actually, there's just, you will find just a very short sentence. They say, okay, you need to perform systematic para-aortic and bilateral pelvic lymphadenectomy. They explain the level, of course, you need to reach during lymphadenectomy, but then there's no details, regarding the histotypes or why you should perform a lymphadenectomy or any new perspectives, in the modern era of precision oncology. Just a brief statement. There are a few more sentences in the ESGO guidelines. And I'm very happy that during the latest ESGO Congress, actually the new recommendations were presented, and so I'm happy that now there is some space in these guidelines to talk about lymphadenectomy, and so in these guidelines they actually give more details, and so they say that the lymphadenectomy is recommended for the high-grade tumors, so high-grade serous, endometrioid, and clear cell histologies. It can be omitted, of course, in the low-grade endometrioid and in the expansive mucinous subtype. And then there is, I think, a gray zone that is low-grade serous and infiltrative mucinous ovarian cancer. It was controversial until the last the guidelines that we had before, but now I think that they made a change in the guidelines, and so we will wait for the final publication. But what they said during the last Congress is that it is not recommended for the low-grade serous, while it is recommended for the infiltrative mucinous ovarian cancer. And I'm sure they had a lot of debate about these subtypes, but I think this is not universally accepted. So there were some concerns regarding these recommendations, and so I think we are going to talk about lymphadenectomy still more.
Yeah, no, thank you for providing that insight. And again, I mean, as you mentioned, the rare tumors and the infiltrative versus expansile, it actually just as an addition to your comments with the infiltrative type, I mean, those patients often are getting treated anyway, so it kind of gets us back to the question of if you have a high grade serous, you're going to get treated anyway. So why the lymphadenectomy? If you have an infiltrative mucinous, you're going to get treated anyway. So why the lymphadenectomy? But we'll get into that in a little bit more in a few minutes. I wanted to ask you biomarkers. How should biomarker profile impact decision, if at all, to perform a lymphadenectomy?
Yeah, so this is what I thought it was gonna be, like the most original section of the paper, because actually this is not depicted in the guidelines, and of course all the studies we have about lymphadenectomy were performed in an era where we didn't have bevacizumab or PARP inhibitors or all the targeted agents we have now. So I think that now biomarkers are really essential when we decide about lymphadenectomy, because I'm sure we're going to talk about it, but I want to say that there is no therapeutic role for lymphadenectomy. Okay, so there is no survival benefit demonstrated in any study. There are some suggestions for the clear cell ovarian cancer, but again, retrospective evidence. And so the issue of lymphadenectomy is about staging. So it's a diagnostic role because you want to see if you can find occult disease and upstage the disease. And of course, this is important if you change the postoperative management. Otherwise, as you said, Pedro, if you're going to give carboplatin paclitaxel anyway, then what's the point? And so biomarkers in this setting are really important, because if you upstage the disease and then it's an advanced stage, then of course you may offer maintenance therapy. And so if it's a BRCA mutated patient or a patient with an HRD test positive, of course, in this case, PARP inhibitors, we know that revolutionized the prognosis of these patients. So you want to know if that patient is an advanced disease, is an advanced stage, because in that case, of course, there is, an indication for lymphadenectomy, because you may really change the prognosis. On the other hand, if you have a negative HRD test, in that case, really, if you're gonna give chemotherapy anyway, then there is no point. So this is, I think, the issue of biomarkers. Of course, during primary surgery, you don't have this information, so it cannot help you. But for example, when you think about restaging, it's something that you can really discuss, when you decide if you want to operate again that patient.
Yeah. No, and I think again, as you mentioned, this topic opens up opportunities for so many discussions, and I'll again, jump on to your comment about the PARP. And one of the comments I always had, it's like, we don't give PARP to patients who are early stage because we think that the PARP only works in the advanced stage. And I'm thinking like, does the PARP pill actually say, oh, wait, this patient is an early stage, so I'm not going to work on this patient, versus, oh, this is patient's advanced stage, so I'm going to work on this patient. So that to me has always been also a point where I don't really see the strength in that argument either. But I wanted to jump onto you mentioned therapeutic role, and I think it's important to just briefly address this topic because there are still some people who might say, well, there may be some component of a therapeutic role in a lymphadenectomy. Um, can we put this
Yeah,
to
yeah.
rest?
No, I think the answer is very clear about the therapeutic role of lymphadenectomy. Actually, I was surprised, but there is an ongoing study, a prospective study, and hope that we will see results, that it is called the LOB study. And actually, it's like a prospective study that is trying to collect data on the role of lymphadenectomy stratified by histotype and grade. So hopefully we will have, more high quality evidence on this topic. But as far as we know, there is no therapeutic role for lymphadenectomy. So it is okay, it is accepted for the advanced stage disease, but actually also for the early stage. What we have is a lot of retrospective studies and prospective studies. And we have actually one randomized study that is of about 20 years ago and is by Dr. Maggioni, who works in my institution. And of course, this was a study that was performed in the pre-PARP era. There is no differentiation across histotypes, but what we know from this trial is that there was no survival benefit for lymphadenectomy, just a diagnostic role. I think that the confusion comes when, of course, you look, for example, into a lot of meta-analysis that actually include retrospective studies. And so some of these meta-analyses come up with the conclusion that there might be a survival benefit for lymphadenectomy, but these results are driven by retrospective studies. So I think this is why there is still some confusion. But if we look at the randomized trial and prospective studies, what we know is that there is no benefit. Only for the clear cell ovarian cancer, I'm curious about the results of this prospective LOB trial, because there is a strong signal from retrospective studies that actually for the clear cell, which is an aggressive histotype, there might be a survival benefit. So this is still an open question.
Great, excellent. So actually, perfect segue into the next question. As you know, fellows will submit questions for this discussion. And this is Alvin Matthew from Houston Methodist, and he's asking, does histology, the specific type of cancer, determine your decision to perform a lymphadenectomy in your practice?
Yeah. So we talked a little bit about this, but yes, for sure. For example, if you think about non-epithelial ovarian cancer, there is no doubt that, of course, lymphadenectomy is not needed. Regarding the other histotypes, we are going to talk about this because there are several considerations. But if you think about the therapeutic role, you may consider it just for the clear cell ovarian cancer. So this is the only histotype where there might be a survival benefit. For the others, the only, consideration you need to do is if you really, with that information, if you really can change postoperative management and offer, for example, either a de-escalation because you can omit chemotherapy if it's fully staged, or on the other side, an escalation offering, targeted therapies, which are most of the times just for the high-grade serous or high-grade endometrioid. So yes, histotype I think is really important and is what we are missing actually, and hopefully the LOB trial will give more answers based on histotype and grade.
Great. And Giuseppe, this next question comes from Nicole Chris at the University of Western Australia. And I think it also targets an important question as it pertains to clinical scenarios. And we often see these patients who had a hysterectomy, removal of both tubes and ovaries, coincidentally are found to have high-grade serous carcinoma, and they never had any staging. And then, of course, there's discussion about, well, if the imaging is negative, most likely it's fine. So then therefore, let's just go straight to chemo versus the lymphadenectomy. So her question is, um, how often are we finding hidden cancer in lymph nodes that looked perfectly healthy on a CT scan?
Yeah, so this is, I think, the main value of lymphadenectomy. So the main objective is to find, to have a diagnostic role, to find occult nodal metastases that were undetected upon intraoperative assessment or even during, preoperative CT scan. And of course, we have, more advanced imaging now for sure. So patients usually undergo, CT scans with these modern techniques, and so this is very accurate for sure. But what we know from the literature is that even in cases where CT scan was negative, up to one third, if you consider all the histologies, up to one third of cases may have positive lymph nodes. So the rate ranges from 9% to 30-40% across series if you consider all histologies. But this is the percentage we have from the literature, and it's not so low. So this is very important. Of course, this can change in the future, and I think we're going to talk about it, but I guess that probably, I don't know, liquid biopsy or AI will help us, to improve preoperative imaging. But so far, this percentage is, of course, very relevant, and it changes with the histology again. So this is why histology is very important, and also the grade. So what we know is that, for example, for the high-grade serous or high-grade endometrioid, this percentage can reach up to 40% of positive lymph nodes during staging. And of course, it's very very low for the low-grade endometrioid or for the mucinous expansile subtypes, where it is like less than 1%. But again, we are still collecting data because, for example, that study that I mentioned from the Gemelli Hospital actually found that, for example, in the endometrioid ovarian cancer, there is a differentiation between grade 1 and grade 2. And they found that in grade 2, this rate was not below 1%, but it was up to 5%. And so this is why Niccolò, when we talked about this, he told me that at the Gemelli Hospital, they perform lymphadenectomy for the grade 2. So they distinguish between grade 1 and grade 2. And then, of course, for the other histotypes, it's kind of in the middle. So there is a differentiation across, histologies, and this is something you want to consider when you decide whether to perform or not lymphadenectomy.
Great. So this next question targets a potential complication. So Beate Sarta from Latvia, she's asking, what is the risk of a lymphadenectomy? And, many would argue, say, well, it's such a low risk, just do it anyway, and you won't lose anything. So what are your thoughts on that?
Yeah, so I think you know probably more on this about than me, but yeah, just as a recap, because I think these risks are very well known. For sure, there is a risk of a perioperative morbidity, so it is not uncommon to see in our clinical practice, lymphatic cysts or infections, or sometimes even if it's rare, but urinary tract injuries or vascular nerve damage. So there is some perioperative risk that you need to consider when you discuss these procedures. And of course, there is also the biggest issue, that is the lower limb lymphedema that you sometimes see in these patients that can really negatively impact the quality of life. And I think this is very important. Then, of course, there are costs that may be related, to longer operative time for sure, and extended recovery sometimes. But for me, that I mainly do, medical oncology in my clinical practice, I think that the biggest issue is the risk of delaying adjuvant chemotherapy, because if surgery goes well,
Mhm.
then it's okay. But in those cases where you have, infections, let's say, and so you need antibiotics or whatever, you may delay the start of adjuvant chemotherapy. That is an important part of primary treatment for ovarian cancer. And so this is one of my biggest issue. The other one, Pedro, actually is about surgical training, because sometimes I wonder, like, we are really reducing all these indications for these procedures, for example, for lymphadenectomy now in this era of de-escalation. And so I wonder how can the youngest really learn these procedures and really be expert, and so keep the level of complications very low, because otherwise this can improve, in the future. So this is the other thing that I was thinking about, when I thought about the risks of lymphadenectomy, and I think it is, a timely question, and I don't know how we are going to, keep the training for these procedures, but I think this is another point for discussion.
Yeah, no, you're absolutely making an excellent point. And particularly again, gynecologic oncologists, lymphadenectomy in the past used to be like you did this every day. And now, of course, obviously with sentinel lymph node mapping in endometrial and in cervical
Yeah.
cancer, you really have lost that frequency of the procedures. And I would venture to say that most GYN oncologists, even senior GYN oncologists, on a day-to-day basis, it's exceedingly unlikely that they're continuing to do
Yeah.
lymphadenectomy. So very, very, very good point. So Giuseppe, these next two questions are coming from the Policlinico Gemelli. First one is Vincenzo Tarantino. He's asking, so today, how should we decide to perform or omit lymphadenectomy? You talked a little bit about the grade 1 versus
Yeah.
grade 2 at Gemelli. Any other criteria?
Yeah, so I think this is the key point of my paper, and actually the answer to this question I think is outlined in the table, where of course you will find the three main considerations that you need to take into account when you decide whether to perform or not lymphadenectomy, and then you have the final recommendation, And so the first question is what we talked about, the therapeutic role. So you need to ask yourself, am I giving, a survival benefit? And the answer is no, except probably for clear cell ovarian cancer. So then you move to the other question and you say, okay, so the point is about diagnosis and staging. So is it worth it? Like, what is the risk of finding positive lymph nodes? And of course, this changes across histotypes because it is relevant for the high grade, but not so much for the low grade endometrioid or mucinous ovarian cancer. So this is the second question that you need to keep in mind. And the third one is that, okay, but even if I have this information, what am I going to do with this information in my clinical practice? Like, am I really changing the adjuvant treatment? Am I tailoring the adjuvant treatment? So you need to do something with it. And so it can be a de-escalation, for example, avoid chemotherapy if you have a fully staged disease that is confined to one ovary, or on the other side, you want to offer maintenance therapy or even enrollment in clinical trials that now we have. I'm going to talk about it. And so you want to do something new to the patient that can really improve prognosis. So these are the three main questions. And then if you look at the table, I don't want to spend too much time on it, but you really understand why you have, the recommendation for doing or not this procedure for each histotype. And so this is basically what the ESGO guidelines say. So in the high grade tumors, you perform it, low grade, you don't perform it. And then there are the low grade serous and infiltrative. So these rare tumors where you don't have enough evidence, it's very heterogeneous. And so these are kind of gray zones. And I think that you need to discuss this also with the patient to really explain, what are the benefits and risks of this procedure.
Yeah. So the second question from Jamali, and you kind of alluded to, and I'd love to hear a little bit more about it, is Giuseppe Parisi. He's asking, well, what about if the cancer is only on one ovary? Can we just remove the lymph nodes on that side and that's it?
Yeah, I think this is a very good question. And what international guidelines say is that you should perform systematic paraortic and bilateral pelvic lymphadenectomy. But actually, I think that in clinical practice, sometimes we do also monolateral lymphadenectomy, also in my institution, for example. And I think that for a para-aortic lymphadenectomy, there is no doubt because the para-aortic chains are the most frequently involved in up to 70% of cases, while isolated pelvic involvement is in about 30% of cases. So no doubts for para-aortic. The issue is about the bilateral pelvic. Historically, what we know is that the risk of contralateral pelvic involvement is around 10%. So it ranges from 3% to 12, 13% across series, but it's around 10%. So it is not, negligible. So this is why guidelines recommend it. But I think that now we are gaining more evidence. And I really loved a recent meta-analysis that I think was led by Professor René Pareja, and I think it was published in the International Journal, where actually the risk of the contralateral involvement was below 1% in this meta-analysis. So this is something that really, I think it's useful in the clinical practice to avoid bilateral pelvic lymphadenectomy. I think there is a big limitation in this meta-analysis. So because I really wanted to understand why we found less than 1% of involvement rate, while historically it was 10%. And what I found is that in this meta-analysis, actually up to 50% of tumors were mucinous carcinomas, which we know are not so associated with lymph node involvement, and the rate of high-grade tumors was not so high. So I think that data were a little bit skewed, towards subtypes that are associated with low nodal involvement, but still it's something between, let's say, 1% and 10%. So it is reasonable in clinical practice if you have, just the disease in one ovary, the contralateral is macroscopically negative. Sometimes people also perform frozen section of the contralateral ovary, and then if it's negative, then they just go with homolateral pelvic lymphadenectomy. So this is my opinion on this question.
Great. And this question is from Leila Abulatsi from Georgia. And you kind of alluded to it previously. And she's asking, when the patient has an unexpected cancer that was, as I said, it's an incidental finding from a prior surgery, do we send them back to the OR just for lymph nodes? What are your
Yeah.
thoughts?
Yeah, so I think that for restaging is even more controversial than during primary surgery. So what we know is that restaging, peritoneal restaging is recommended. So if not done, you need to go again to the OR. Regarding lymph nodal restaging, guidelines say nothing, actually. There was just one sentence in the ESGO guidelines that was very broad, and they say, okay, if you think lymphadenectomy can change your clinical practice, then do it. But again, like, what does it mean? So I tried to really understand, what this means. And I think that overall, the principles are the same of the staging, but two relevant aspects differ, I think. The first one is that patients need to undergo a second surgery, and of course, this can be performed via minimally invasive approach, and so this helps. But what happens is that sometimes you really delay, as we said, the start of adjuvant chemotherapy. So sometimes you see the patient that was referred from another center after 2 months from prior surgery. Then again, you decide whether or not to operate again the patient, and then you start chemotherapy after 3 months from diagnosis. So I think this is one of the main issues with restaging. And the other one is that at this time you have the information about BRCA mutation and HRD, hopefully. So you have biomarkers. And so I think that when you decide if you want to perform or not lymphadenectomy during restaging, this is what changes compared to the primary staging. And so if you look at my table, this is why, for example, for the high-grade serous or endometrioid, if you have an HRD test negative, then you want to discuss if you really need lymphadenectomy, because you are going to give carboplatin paclitaxel anyway. Maintenance therapies did not significantly change prognosis in this setting. And so this is something that I think you need to discuss with the patient.
Yeah. So this question comes from Lucia Rivero, your own institution. She's at the European Institute of Oncology, Milan, and she's asking basically the obvious question as well, sentinel lymph node mapping in ovarian cancer, early stage ovarian cancer. Should it be, what's the role in when you actually are doing the primary surgery? Is there a role after the coincidental finding of an ovarian carcinoma?
Yeah, so I think this is a very interesting topic, and there have been a lot of publications over the past few years. So this is why I think also this topic is not so old, because we are collecting more evidence. And I think it's not just about sentinel lymph node. Now we potentially have some new tools, as I said, like, for example, artificial intelligence or also liquid biopsy. And of course, the rationale of using these new tools is that you can keep the diagnostic role of these tools. So understand if nodes are positive or not. And of course, give less comorbidities, have a non-invasive approach to really understand if nodes are positive or not. So I looked into the evidence about sentinel lymph node, and there are a lot of it is very challenging. It is very heterogeneous. There are a lot of issues regarding the technique, what type of tracer, what is the injection technique, what is the injection site, because of course it's different than other tumors. Should be the uterovarian ligament, but it's very challenging. And so the data we have are not so reassuring. So as of now, we cannot replace lymphadenectomy with the sentinel lymph node. And actually, the latest study, that was the CELLI trial from Gemelli Hospital, had negative results. You know, the accuracy of this procedure was not so good. So my personal opinion is that the future, will probably rely, be in the liquid biopsy probably, because probably we will find, a specific threshold where we can really understand if the disease is advanced or not. So hopefully this will be, something that can replace lymphadenectomy, or even AI, applied to preoperative imaging. But I'm not a surgeon, so I've never performed, a sentinel lymph node biopsy in ovarian cancer. But what I learned, also talking with Dr. Zanagnolo in my institution and Professor Aletti, is that this procedure is very, very challenging in ovarian cancer. So we are not sure that it's going to be successful like in other cancer types.
Absolutely. So, Giuseppe, we come to the conclusion of the podcast, and as tradition, we now ask a question that was generated by AI. And I do have to say, this is likely the longest AI question of all of the podcasts that I've done. But here's the question for you. Your review emphasizes that lymphadenectomy is recommended in high-grade serous tumors, primarily to identify stage 3A1 disease and trigger eligibility for PARP inhibitors or bevacizumab. However, since many clinicians already consider adjuvant chemotherapy standard for 1C tumors, 1C serous tumors, if a patient is HRD negative, where the benefit of maintenance therapy is modest at best, could we safely argue that lymphadenectomy offers no meaningful change in management and should be omitted regardless of the high-grade label?
Okay, let me say that this is not just the longest one. I think it's also the most confusing one, not so smart. So I'm very happy about this because, I think human brains works differently. So yeah, also because, adjuvant chemotherapy actually is recommended not just for stage 1C, but also in stage 1A. So this is the first answer to this question. But I think that the point is what we said about biomarkers. So if you know that the patient, for example, is HRD test negative before surgery, this does not happen often. It's mostly when you restage the patient. But if you have this information, then of course you might consider omitting lymphadenectomy if you are giving, of course, chemotherapy anyway, because it's a high-grade serous ovarian cancer. So I think, of course, that you can omit it. But one last comment to this question is that now it's not just about PARP inhibitors and bevacizumab, because now we have, a lot of trials, 5, 6, or even 7, I think, that we are about to start in my institution in the first line for the HRD test negative patients, where you use an ADC in the maintenance setting. And so if you believe in these trials, and if you have these trials available, then, like for the issue of PARP inhibitors, you may consider lymphadenectomy, because if you upstage the disease, then the patient has the opportunity to be enrolled in this trial. So I think this is, evolving very rapidly. And so I was happy after this presentation I prepared for Professor Colombo to learn that this topic is not so old. And I'm happy also that we are still discussing about it. And I think that this paper can really be helpful, even looking at the table, it can be really helpful in our clinical practice and raise new discussions in the modern era. So
Well, Giuseppe, thank you so much. Always very enlightening to listen to your discussions. I always love reading your manuscripts, learn a great deal. And thank you again, of course, obviously, for submitting it to our journal and for your time.
thank you very much. Thank you very much.